Air pollution is associated with a lot of things, and the question was, haven't we heard of these mechanisms sometimes before? So you've heard about some of them earlier, so let me just mention briefly some that didn't show up. We have a number of studies showing that air pollution is associated with impaired endothelial function. We have a lot of studies showing that air pollution is associated with changes in autonomic function. We see increases in endothelium levels. We see increases in inflammation and oxidative stress, evidence that it activates NF-kappa B pathways, for example. And that all sounded kind of familiar. And so back in the 90s, we thought, well, if you push on some of these pathways far enough, the responses may start to get nonlinear, and that suggests that maybe diabetes might modify the response to air pollution. So that's what we started looking at. And so the question is, what evidence is there that that's true? And there's evidence from a range of studies, starting at the simplest level with studies of administrative data that we can get from health systems, moving on to physiological studies and biomarker studies. So the administrative studies, what we did here is you can get mortality data. It's getting harder and harder to do this, but you can get mortality data from the government, and you can get hospital admissions data. And so the question is, A, do more people die or enter the hospital for cardiovascular disease on high air pollution days? And by the 90s, we were showing that that was true. We had quite a number of studies showing that when air pollution went up, that was followed by more people dying of myocardial infarctions or being admitted to hospitals for myocardial infarctions, for example. And so then the next question was, are diabetics at greater risk of those events? And so back in 2001, we published a paper, and Goldberg at Montreal also published a paper in the same year showing that the answer was yes, at least as far as we could tell in administrative data. So what they did in Montreal is they did a data linkage analysis where they went back and they identified from the single healthcare system that they have in Quebec people who had diabetes, and then they looked at how much the rate of death for those diabetics went up on high air pollution days versus everyone else. And what they found was the increase was greater. What we did is we looked at Medicare data, which is the hospital insurance data in the United States for people 65 and older. And again, we went back in records to identify people who were diabetic, and we asked, are more diabetics being admitted to the hospital for cardiovascular diseases on high air pollution days relative to non-diabetics? And again, the answer was yes. So since that time, there were in the early 2000s a bunch of other studies in various cities, in groups of cities, in Italy, in Shanghai. There have been these multi-city studies in the United States and Europe. We're now getting up to 200 cities in the United States in these studies that we do. And the pretty consistent result is diabetics are responding more than non-diabetics to exposure to, and I should clarify, here we're talking about particles, okay? So for example, here's one study that we did using people in the Medicare cohort in Cook County, Illinois, which is Chicago. And so what we did in this study was we identified people who had diabetes, and then here we're not looking at hospital admissions. Here we're looking at subsequent mortality, okay? And we looked at various conditions that people may have had identified from previous visits and whether they modified the risk of dying subsequently on a high air pollution day. And what we found was, interestingly, nothing for COPD. They did not appear to be more susceptible, which was the biggest surprise for me. I still don't know why that happened. But what we see is that people who have previously had a myocardial infarction had almost a threefold greater increase in the risk of dying in a subsequent high air pollution day, and diabetics had twice the increase in the risk of dying compared to people who didn't have diabetes. And so these are the relative effect modifications we found in that study. So there are lots of administrative data that supports the notion that diabetics are more susceptible to air pollution. Well, there are also physiological studies that back that up. So in a number of cohort studies or panel studies, and by panel studies, what I mean is we go out and we recruit 50 people, and as opposed to seeing them every 5 years, we see them every week. We say, okay, come back 5 times, right? In 5 consecutive weeks, and we will do various measurements on you, right? And so then we can control for person and look at, if this week your medical examination occurred on a day that happened to have higher air pollution than last week or next week, did we get different results? So that's a really nice way of controlling for confounding because it's the same person. So there are only things that can be confounders are things that vary between last week and this week, and not between people, like BMI or, cigarette smoking, etc. So, and what we find from these studies or from some cohort studies is that there are changes in heart rate variability, in QT intervals, ST segments, some dispersion parameters, and those tend to be greater in diabetics than in non-diabetics. So for example, the normative aging study is a cohort we have in Boston. These people were recruited in 1965. They were free of chronic disease in 1965. That's generally not the case anymore. And so lots of them have diabetes, and we see stronger effects of particles on heart rate variability in diabetics and in obese people in the normative aging study. In the MESA study, which is a longitudinal cardiovascular cohort, it's the multi-ethnic study, they see stronger effects on various autonomic measures and other measures like this in people who have metabolic syndrome. Now, it's not all uniform. In the Women's Health Initiative, none of these things seem to modify the response to air pollution. There was a Korean study where fasting glucose modified the results. QT prolongation, we're the only ones who actually looked at whether diabetes modified the response to QT prolongation, the air pollution response, and we did find an interaction. So we found stronger effects on QT segment length in diabetics than in non-diabetics, again of particulate air pollution. So we found, a nice randomized controlled trial going on in Boston of, some diabetes drugs that I would not recommend prescribing to your patient. But we looked at the controls, okay? And we looked at flow-mediated dilation of the brachial artery, and we found a bigger effect in diabetics than in non-diabetics. Liu looked at, I think this was also MESA, and found decreased flow-mediated dilation. Again, in diabetics, stronger effect with air pollution. There were some chamber studies where people are brought in and exposed for a couple of hours in an exposure chamber. So those are short-term exposures to higher doses, so it's not quite the same thing. They found changes in baseline diameter, but not FMD. And then there was another study that did find effects on FMD. And some of them looked at interactions with hemoglobin A1C and reported them. There were a number of biomarkers of endothelial function like ICAM and VCAM, Van Willebrand's factor, and the effects of particles on those were stronger in diabetics. The effect of ICAM and VCAM was stronger in the NAS in obese people. There was, again, an interaction in ARIC, which is another cardiovascular cohort. And then we did this bus study. You know, it's really hard to get permission to take vulnerable people and put them in an exposure chamber because, you know, the ethics committee says, you're exposing them to what? But you can put them in a bus, right? And that's pretty much the same thing, right? You know, you can't expose them to diesel pollution by putting them in a chamber, but you can recruit elderly people with diabetes and heart disease and say, you know, we're going to take you to this, you know, zoo, and, you know, you'll have a nice trip, and we'll put you in this bus, we'll pick you up at the elderly housing complex, and we drive you down this highway full of belching trucks for an hour, and we take you to the zoo, and we take you back, and there's no problem with that. So in that bus, we had, you know, a particle counter to measure ultrafine particles and an ethylometer to measure black soot particles, and they were pretty high. You know, we wouldn't have gone any higher in an exposure chamber, but, you know, this we could get approval for, and what we found was short-term exposure, an hour in the bus, led to increases in inflammatory markers in the diabetics. And it wasn't significant in the non-diabetics, really. So here's some of the, This is another study we did back in Boston, no bus. These are the normative aging study people, right? They're in their 80s, they don't leave home much, right? And we have a land use regression model that estimates black carbon, which is diesel soot, exposure at everyone's home address. And this is, for example, the percent change in IL-1 beta in people without diabetes and people with diabetes and people with diabetes without coronary heart disease and with coronary heart disease. And basically, we're seeing increases in the diabetics. And this is IL-6, and this is TNF-alpha, and this is IL-8. And so the basic story is, you know, there's nothing going on in the non-diabetics, and we're seeing, you know, 20% increases in some of these cytokines, or sometimes 50% increases, associated with home exposure to black carbon particles if they're diabetic. So people yell at you because there are a lot of inflammatory markers, and they start uttering words like multiple comparisons. And so one way to get out of that is to create a latent variable for sort of increased inflammatory status that you feed all of those cytokines into, and then just analyze that latent variable. And so this is a study that we did looking at that. And so this is percent change in that latent variable of inflammatory status with black carbon at different moving averages in people with diabetes and without diabetes. And you can see the effect is with some longer averaging times, but it's a lot bigger in the diabetics than the non-diabetics in this particular analysis. You've already heard that there are animal models of the effects of particles. They didn't all look at interactions with diabetes, but it's important to note that those models which show increases in atherosclerosis, increases in other markers of endothelial dysfunction, decreases in plaque stability, there tends to be a much greater response if the animals are on a high-fat diet, which is at least suggestively supportive of the epidemiology studies of an interaction with diabetes and particles. This is a study looking at somewhat longer-term exposure, and I think I'll just skip over it. So if diabetics are really more susceptible, what's another way as an epidemiologist I could try to find something that made me more comfortable with that observation? Well, I know that diabetes results in greater oxidative stress, so maybe other things that increase oxidative stress might interact with particles as well. That might be an indirect way to make me feel more comfortable with the results. So one of the things that modifies oxidative stress is genes. There are genes that are related to the expression of antioxidant defenses, and we looked at interactions with them. People at the University of Southern California have looked at that with respect to respiratory disease in children. And I think the general finding is that there seems to be interactions with polymorphisms along this pathway with the responses to particles in a range of different outcomes, from these endothelial markers to autonomic markers to lung function in the presence of asthma in the California children's cohort. And we've also seen, markers of oxidative stress directly in a number of studies being associated with particles. So this, again, all sort of makes sense and suggests that the interactions with diabetes are probably real. There are also studies that have looked particularly at obesity rather than diabetes, but that's the general finding there. So I want to move on now to the more, I don't want to say more interesting, but let's say more controversial question of, can particulate air pollution actually increase the risk of developing diabetes? So there have been about 7, maybe 8 epidemiology studies by now that have looked at this. Not enough, okay? But there's a study that looked at incidence of diabetes and found an association with traffic pollution in women, but not men. There was in the nurses' health study, the weakest evidence is from my data. In the nurses' health study, we have this nice land use regression model. We can estimate long-term exposure at their home address. We also did it for the health professionals study, and we didn't see much. We saw more in the nurses, which may be interesting because The addresses we have in the health professional study are actually where they work, not where they live. Medical offices tend to have air filters. So there's very little particle concentrations where they work. So it may be lousy exposure for that. There was some association with traffic density in the nurses, but still nothing significant with the modeled particle exposure. There was an ecological study looking at county level PM 2.5 and the BRFSS surveillance data, and they saw something, but that's not something you would want to rely on too much. Again, there was a Dutch study that found evidence with the amount of traffic within 250 meters of your home, but not with any modeled air pollution. The Salia study, though, which is a cohort of elderly women in Germany, did find an association between modeled particle exposure and diabetes. There was a Canadian cohort that found an association between modeled long-term PM 2.5 and diabetes incidence, and a Danish cohort that found an association with NO2. So that's where the epidemiology is on that with cohort studies. So we tried another thing. We looked at all Medicare beneficiaries in New England, and again, we have all of them, right? We have their zip code, their postal code. We used satellite remote sensing to estimate the exposure, and I want to thank the Environmental Health Fund for funding the person who did that, Itai Klug. And so we were able to estimate both long-term and short-term exposure for these people. And we looked at more than diabetes, but short-term exposure, we found associations with hospital admissions, but we saw much greater associations for all the things we looked at with long-term exposure. So this is saying that in postal codes with higher long-term average PM 2.5, the rate of hospitalization of patients with diabetes as either a primary or a contributing cause is higher than in postal codes with lower particle concentrations in the air. So this somewhat supports the notion that you might be having an effect on diabetes incidence. Otherwise, why is the rate noticeably higher? More disturbing than what's happening in 80-year-olds, where the incidence of diabetes after age 65 is perhaps not the biggest thing that we're worried about. It's not trivial, but in these two German birth cohorts, they found insulin resistance was increased in the children who had higher exposure to particles and NO2, and there was also an Iranian study that basically confirmed that for particles. And if we're, precipitating the development of diabetes in children, that's a serious burden for society. And so there's a suggestion in a couple of studies that might be going on. There's a large HMO in the Boston area that recruited a birth cohort called Viva about 12 years ago. There are 2,200 live births that have been followed starting in pregnancy, and this is the odds ratio for impaired glucose tolerance in the mothers using the central site monitor of air pollution in Boston and using our spatiotemporal model based on the satellite data to estimate exposure at the home of the mother, and we see, more than 2.5-fold odds ratios for impaired glucose tolerance during pregnancy associated with PM2.5 concentrations in the Boston area. And I should say that, so these kids were born around, let's say, 2000, 2002. It was higher, but back then the average PM2.5 in the Boston area was about 11 micrograms per cubic meter. So I don't know what it is in Tel Aviv, but I'll bet a lot of money that it's bigger than 11. Okay, so these are pretty low doses, and we're seeing, pretty steep dose response curves here. So how do you put that all together? Oh, and there's a Taiwanese cohort of the elderly that saw associations with fasting glucose, and glycosylated hemoglobin. You've already heard about these mice studies, which were really nice, and so I don't want to go over them again, but there are some other studies looking at, again, as you heard, what's going on in adipose tissue with macrophages or phosphorylation of AKT, and changes in brown fat. So there's some animal support for these findings. So the conclusions I would come to is, do we have enough evidence to conclude that diabetes modifies the response to air pollution? And I would say almost certainly, especially for particles. There's just a lot of stuff out there, both epidemiologically and mechanistically. Do we have enough evidence to conclude that particles or other air pollutants increase the risk of diabetes? Well, it's suggestive, particularly for traffic particles, but I would say that we're not there yet. But it's looking like there may be something going on. And so I think that's, a critical area for further research to either confirm or refute this existing data. And thank you very much. Have we done experiments where we decreased particle exposure to see if the risk is decreased?
Yeah, right.
Okay, well, if the hypothesis is, does long-term exposure to particles induce diabetes, I don't think that that would be a good study design because, I don't think it would then go away. But if the question is, have we done studies to see whether, other health effects of particles change if you decreased particles? Yes, so there have been a bunch of studies like that. One thing you can do to do a study like that is you can end communism, which results in a great reduction in exposure to air pollution. And so there are a bunch of studies in East Germany that have showed that particle exposure has come down, acute bronchitis rates in children have come down, lung function in children have gone up in the same communities with just, school children that hit third grade before, a year or two after, and a few years after the wall came down. There was a study done in, the other thing you can do is you can trigger a strike. So there were two studies that Arden Pope did, one in the Utah Valley where there was a strike there's a steel mill in the bottom of a valley surrounded by 4,000 meter mountains. which is not the ideal place to put a steel mill, but if it goes on strike one winter, it cuts the pollution levels in half, and it turned out there was a dramatic drop in hospital admissions of children for respiratory disease. There was a similar study done looking at a copper smelter strike and mortality. Strike went on for 8 months, and the mortality rates in that states went down for 8 months, and then they went back up again. In the 6-city cohort study, we have a cohort of people who were recruited in 6 communities in 1975, and there was a big drop in air pollution due to regulations that occurred in the 90s. And we looked at following them up to the 90, and then in the 90s, we looked at the change in air pollution and the change in mortality rates, and we got the same slope. So we've done that, but I don't think there have been any studies that have tried to produce a long-term reduction in air pollution and see what that does to the diabetes rate. It's a little tough.
One more thing, if I can ask, what about the mechanism? If you think about mechanism of how you get this stress, the mechanism of when you try to find something, you have to connect
the mechanism. Yeah, so there was a nice, I don't have the slide, there was a nice study that was done by a toxicologist at Harvard. And what she did is she developed this in vivo immunofluorescent assay for reactive oxygen species. So she could look at live animals and look at ROS in the heart and lung. And she took those animals and she put them in filtered air. And over 5 days, breathing filtered air, compared to starting out breathing Boston air, there was about a 1/3 reduction in the ROS levels in the lung and in the heart. So oxidative stress being one of the, hypothesized mechanisms whereby this can occur, there's certainly evidence that demonstrates that reducing particles reduces oxidative stress in animals. What went down in East Germany is air pollution based on coal. What went up in East Germany, since with unification they decided to pay people the same amount of money in East Germany as in West Germany, they got a lot more cars. And what went up in East Germany was traffic-related air pollution. And so before the wall came down, there was a much lower rate of asthma in East Germany than in any place in Western Europe, and the same was true in Poland and in the Czech Republic, etc. Eastern Europe had much higher rates of bronchitis and much lower rates of asthma. When the wall came down and the number of cars dramatically increased, the asthma rates went up with the traffic pollution.